Welcome to AETCM. Today we are going to discuss about a 58-year-old male who came to our complaints of acute onset of right side weakness. So 15-year-old male was brought to have complaints of sudden onset of right upper limb lower limb weakness since past 2.5 hours. So in initial 10 seconds assessment was conscious or in obeyed to my commands. So we went to the primary survey. His air was patient, there was no signs of any coding or secretions or bleeding was noted. And breathing, he had a symmetric and adequate chest situation for noted. And there was no added sound, there was no stridor or audible wheeze anything noted. He had a respiratory rate of 18 per minute and maintained a saturation of 98% in room rate. Circulatory part, good peripheral pulses were felt and heart pulse rate was 76 per minute. Blood pressure recorded was 200 by 1 millimeters of mercury. At this point, we also arranged to get an IV access on the opposite side. So on the left side, we secured a large for IV access. Disability part, he had a full score of GCS. He was obeying to command with full score of GCS, but we noted reduced power on the right upper and lower limb. He was not able to move at all his upper and lower limb. And pupils are equally reactive. Exposure part, temperature was normal, and we was provided blanket to prevent hypothermia. And at this point, we also checked the GRBS was 132 milligram per deciliter. So on reassessment now at this point, his airway is maintained, taken and maintainable. Breathing is okay, saturation maintaining. Circulatory part, he had elevated blood pressure. Disability part, he had a full score of GCS with right side weakness.
So a patient with right side weakness with elevated blood pressure. Okay.
So the GRBS we checked was 132 milligram per deciliter. We also took a BPG. It was not showing any metabolic disorders. There's no acid arrangement. And we also got electrolyte with the normal in the solid. Potassium was 4.8, sodium was 132, and that was also normal. We took an ECG, it was showing only normal sinus rhythm with a 76 beats per minute. So the sample is.
So what electrolyte abnormality were you suspecting?
One thing is actually severe hypokalemia can actually cause these things, certain weakness can cause, and also.
What will be the classical presentation of hypokalemic diagnosis?
Will like severe.
It will be mostly bilateral. Then what will be the history be like?
Usually there will be like a biological reason like trekking or
Constipation. That is associated hypokalemia. Patient usually might be presenting with a high carbohydrate meal. Post high carbohydrate meal, patient coming with bilateral lower limb. Bilateral symptoms will be there.
This patient we report deeper in the history. So basically, he's a non-case of type 2 diabetes systemic hypertension dyslipidemia. Since about 2.5 hours back, he had a sudden onset of right side upper limb lower limb weakness and with mild deviation of angle of mouth to the left side. It all started suddenly. Before that, it was completely asymptomatic. So they took him to a nearby hospital, and there they assessed about an MRI. MRI stopper was done. It was showing an acute infarct in the left hemisphere territory. So they advised for further management, but they brought to the hospital for further management.
Okay, so is the patient still in window period?
In window period.
In window period, already MRI diagnosed. Suppose this patient comes to our hospital, what will be the first investigation?
Our priority will be to get a CT to rule out any bleed.
First, we will have to rule out hypoglycemia. Then we will have to do a CT and rule out. Okay. Suppose this patient is coming with the history of right side weakness since 2 hours after waking up. What in this patient will you do? Patient woke up with this complaint.
The thing is actually we'll ask for a history like when was the last time patient was found to be normal. If it's like in the previous year or something, it's most probably a post-interference stroke. So at this point, we prefer to go for like a detailed evaluation. We go for MRI with the angiogram preferably, so we can actually assess the.
And if you are in doubts, like patient came, patient complained that patient started this weakness after waking up from sleep. So we are confused whether the patient was in window period, is in window period or not.
So basically we do an MRI stroke protocol and check the flare images. If at all there have been changes in flare images, then it means to say that it is out of window period. So if there is no thing, then it is within window period. In that case, we can still thrombolize.
Okay.
So if it's showing only the diffusion rate images and not in the flare, it's most probably acute stroke. So once it has come up to the flare, then it's most probably established. So we have to go for later consolidation. So this person basically he came with a diagnosed case of stroke within about 2.5 hours after the initial onset, and it was not showing any signs of bleed also. So we also took asked for another history also. There was no history of any recent history of fever, any headache, any acute history of any vomiting, palpitations, seizure, or any loss of consciousness. So
why did you ask those?
one thing is actually any other suggestion of any this thing, seizure or anything like that, and also any bleed, or any bleed, like sudden headache, exercise, and all that.
Okay, so anyway, MRI proven there is no bleed as such. Such things should be asked, like if there is any fever, ulcers, or any these histories and all, it can be because of a meningitis causing a vasculitis and a stroke. Or else, if this patient is in post-ictal state, it might be a Todd's palsy. And post-seizure thrombolysis is also a contraindication.
So he doesn't have a non-allergic history, and there's no history of relevant surgical history or anything. So this is the only event that described as the previous contributing event. So when with the system examination, general examination, he's conscious or in the ability to make amends. System examination, basically he had a full score of GCS, but there's notable facial palsy was noted. There was also mild slurring of speech was also there. And power was 0 by 5 on both right upper limb and lower limb. But there was no complaining of the sensory loss as such. So at this point, we calculate the NIH scoring to be 10. So with the scoring of 10, with right side imbalances.
What is the importance of NIH score?
The thing is actually NIH scoring actually we can be used to like define a cut point like whether the stroke is mild, moderate or severe. So anything less than 5 or less than 5 we put it like mild, 5 to 9 we put it as moderate, and anything above 9 we put it as severe. And above 25 is very severe stroke, which is not eligible for thrombolysis.
So what is the cutoff for thrombolysis between 5 and 25?
5 and 25.
What is the maximum NIH score? 45.
45.
Okay. So we will be thrombolizing only between 5 and 25. Except in some exceptions, we will be thrombolizing if NIH is less than 5, which are these.
Brainstem stroke.
NIH is less than 5, but still, if the patient is having some subfunctional problems, like the patient is having severe aphasia or complete homonymous hemianopia, like vision problems, speech problems, and that means that will affect the patient's functioning. So, in such conditions, we will have to thrombolize even though the NIH is less than 5.
So this patient, considering the condition, we have planned for thrombolysis.
Here NIH is 10.
So there's no history of actually taking any antibiotics or anything like that. Only things on OHs and this antihypertensive medication. So we planned for thrombolysis with.
But his BP was high, no? What is the BP cutoff for thrombolysis?
The thing is actually before initiating thrombolysis, we have to bring down the BP to at least 180 systolic and 110 diastolic. And once it initialized, we have to maintain systolic of 180, less than 180, and 105 diastolic. This we have to maintain at least for 24 hours period. So this patient on initial level itself actually it was about 200. So before starting we had to reduce that. So we prepped him for thrombolysis. We arranged, explained the procedure to the bystanders and everything.
How did we reduce BP?
So this patient we already got a secured an IV cannula. So at this point we preferred IV medication. So we started him on IV labetalol. Initially we give 10 mg labetalol and again one more dose repeated after about 15-20 minutes. Then we put him on continuous labetal infusion. So initially we started with 1 mg per minute was started. Then we had to cycle it up to 2 mg per minute. 2 mg per minute. So this was continued and we were able to bring it around 160 systolic. So when we started thrombolysis.
Then was there any contraindication for thrombolysis for this guy?
This patient, no as such.
What all are the contraindications?
One thing is actually any history of any recent surgeries or anything like that, and any history of any recent infectious bleed or anything in the past 6 months or something like that, and also any persistent elevated blood pressure, then again is a related contraindication. And also sometimes
from the brain, if we are starting any AV malformation, any intracranial space occupying lesion, or any hemorrhagic stroke, or any history of ischemic stroke in the last 3 months, or any history of thrombolysis.
And relatively also patients having any like low platelets, elevated INR, and also
what is the platelet cutoff?
Less than 1 lakh. 1 lakh.
1 lakh.
Anything below 1 lakh actually it is related contraindication.
INR cutoff?
1.7. So this one actually we can, if you initially readily available, we can give corrections and then plan for thrombolysis also.
And other parameters like we need to check for the sugar. If sugar is less than 50, that is also a contraindication. If there was any recent history of any road traffic accident in the last 14 days or any GA bleed in the last 3 weeks, these things are contraindications.
So as per our patient's concern, one of these things are there. So we plan for a thrombolysis. So one thing is we secured the IV access, and also at this point we put him on Foley's catheter and also right tube aspiration, this RT, because actually he had some difficulty in swallowing also.
Why before thrombolysis?
Because after thrombolysis, this thing will be difficult because it can actually bleed and cause complications. So we put him on RT, we put him on Foley's, and also we got a good adequate IV line also was secured. And then we planned for thrombolysis. So this person's body weight was actually coming to be 65 kilogram per 65 kilogram. So we chose the drug Altiplase. So the dosage is 0.9 milligram per kilogram. And in that, the 10% we gave us a bolus over the first 1 minute, and the 90% remaining we give over a period of 1 hour.
So a dose of Altiplase is 0.9.
0.9 milligram per kilogram.
So how much?
This person has 75 kilogram body weight. So we got a 67.5.
That was a required dose.
Required dose.
Okay. Suppose the patient is coming to you and patient weight is 100 kilogram. How much will be the dose?
It's a maximum dose of anti-patients, not just about kilogram.
What is the maximum dose? Suppose one patient comes with a weight of 120 kg or 150 kg. So what is the maximum Altiplase we can give? 90. Maximum 90 kg. Okay. So in this patient it's okay, but otherwise 90 kg is the maximum we can give. Okay.
So this one we gave 76.75 milligram as binding bolus, and 60.75 was given over the period of 1 hour.
How should you monitor the blood pressure during thrombolysis?
Thing is, our idea is to maintain a blood pressure below 180 systolic and 105 diastolic continuously over the period of this thrombolysis and up to 24 hours. So initially in the first 2 hours we have to repeat our vital annually at least every 15 minutes. Then after that at least 30 minutes over the past next 6 hours, and then at least every 1 hour the vital should be reassessed and recorded. So our plan is to put this in continuous monitoring. One thing is actually blood pressures and everything. Second is actually we have to monitor the GCS also. Because any time during this first 24 hours there is high risk of IC bleed following thrombolysis. So even a 1 point drop in GCS, we have to be cautious and we have to do a CT as early as possible to prevent any bleed. So and even if otherwise also once thrombolysis is completed within 24 hours, we have to do a repeat CT to rule out any IC bleed. So this patient's thrombolysis period was uneventful. Basically, we give thrombolysis, we maintain the blood pressure around 160, 180 like that. But actually, there was some difficulty in controlling the blood pressure also. So once thrombolysis was done, we took a repeat CT.
What will be the problem if you control the BP too much?
Thing is actually, if we immediately drop down the BP or even if we bring it too low, also it can actually affect the ischemic phenomena. So the one thing is actually we should not opt for drugs which can suddenly drop the BP, and also the lower limit should also be a bit more high. So at least we are above 140 we have to maintain the cerebral perfusion. So there have been multiple studies actually which try to maintain a lower blood pressure also during thrombolysis, like around 140, 120 like that. But compared to this cutoff of 180 by 105, there didn't show any additional benefits. So now also as recommended guidelines are saying below 180 by 105 is good enough for thrombolysis. So this person actually after thrombolysis we took care for a repeat CT and it was showing some microbleeds.
Okay, why was it repeat CT done?
Post thrombolysis actually we do a repeat.
We usually do within 24 hours. No, why this patient was done? Any fall in sensorium or any worsening?
No, thing is actually here his blood pressure was consistently going up.
Okay.
Even after reducing the infusion was going up, so we took a repeat CT. It was showing actually some microbleeds in the left side, but it was only put on continuous monitoring.
Okay. Suppose this patient is developing post thrombolysis IC bleed. How will you manage?
One thing is mainly any other IC bleed actually we have to maintain the hemodynamics and everything. We have to prevent hypertension. We have to maintain normocapnia, prevent hypoxia and everything. And it's like managing an SH. We have to manage the bleed.
That is the management of IC bleed, but this is like a post thrombolysis bleed. So what is along with the IC bleed management, we will have to the thing is patient is having that if at all the patient is getting this Altiplase infusion, we will have to stop that infusion, stop thrombolysis immediately. Then we will have to inform the neurosurgeon and hematology. That should be informed. then we will have to give tranexamic acid. Tranexamic acid, and when you check the APTT, INR and all, this will be very much prolonged because this patient got thrombolysis. So this thing is tissue plasminogen activators acting in the body. So in this condition, we will have to arrange for FFP and cryoprecipitate, and we will have to immediately transfuse with 10 bags of cryoprecipitate. Okay, so we along with IC bleed management, we will have to do this also. Arrange for the cryoprecipitate, transfuse cryo, FFP. Cryo is the first one preferred. So 10 bags of cryoprecipitate, FFP, tranexamic acid, along with the neurosurgery and hematology intervention.
This question initially we put him only on hemodialysis and continuous monitoring, but he was actually okay. So.
How was his power and all? Did it improve?
Initially, actually, we couldn't notice any sudden improvement in the listening power, but over about a period of about second day, there was some mild improvement in the power. So after that, we also started initiating more physical, and PMR also was initiated for further management.
Other than the thrombolyzing, what else should we manage in a patient with acute stroke? What other things should be monitored?
One thing is actually if the person is already on anticoagulants and everything, which we have to restart after 24-hour period because considering his previous history and all that. And also we are evaluating for the cause of the stroke.
That is for young patients.
Young patients. There is a cardiomyopathic stroke or something like that, we have to rule out.
So we need to take an ECG, echo to rule out cardiomyopathic
and
stroke.
also not any hyperlipidemia or anything like that, we should rule out.
Then immediately, along with the BP monitoring, what else should we monitor?
One thing is continuous GCS
and GCS monitoring should be monitored.
Urinary.
Those things, any bleeding things should be monitored. Then patient should not go into hypothermia or hyperthermia, or patient shouldn't develop fever also, because fever, these things can worsen the outcome. And along with that, glycemic control. What should be the glycemic control? Between 140 180, glycemic control also should be kept.
So this patient actually is post-thrombosis underwent full except for the finding in the CT.
Microbleeds.
But in progress after this thing, so we improved over time. Suppose actually patient we are getting like an ambulance call or something called a Cincinnati 3 hospitals close. We can actually use Oxford Hospital. Just really complex with 3 things. That is one is patient group, armed with an abdominal speech. Anything is positive, we have about 72% of acute stroke, and 3 is positive, we have about 85% chance of acute stroke. Which we can actually teach our EMT people if they're going to pick up a case outside hospital.
When will you rule out stroke if the patient is, if we are bringing a patient with suspected stroke, when will you rule out stroke? If there is a history of seizure and syncope.